Welcome to More Than Miles. Whether you're on a run, driving, doing laundry, or cleaning your house, thanks for taking us along. On this podcast, we believe that our athletes are so much more than their body and sport. So we dive deep with conversations and expert interviews to widen the lens on what it means to be a happy and healthy endurance athlete. I'm Dr. Kate Mihevik-Edwards, physical therapist, author, educator, and former endurance athlete. Through 12 plus years of successfully treating thousands of frustrated athletes and navigating my own health struggles, I've learned so much, and I really can't wait to share it with you.
And I'm Dr. Casey Sinders. I'm a physical therapist, runner, and advocate for mental health and endurance sports. As an athlete myself, I understand the endurance athlete lifestyle and the impact that injury can have on our daily rhythm. I'm also known for my T-Rex costume and Wiggle Wednesday series on Instagram. Our goal is to always keep our athletes healthy on and off the road. As a wise woman named Pink once said, let's get this party started.
Welcome to More Than Miles. Today, I'm really excited to introduce to you all Dr. Blair Green. She's a doctor of physical therapy and a pelvic health specialist. She owns her own clinic, Catalyst Physical Therapy, on the northern side of Metro Atlanta. And she's a very good friend of mine, a colleague, and the co-author of the book, Go Ahead, Stop and Pee, Running During Pregnancy and Postpartum, that we published in late 2019. Thank you so much for being on this podcast today, Blair.
Thanks for having me. I'm so excited because I feel like we used to do this every day and now we don't do it at all. So I'm super excited to see you and hang out.
I know we did. It was actually funny while we were writing our book, we did talk at least once a day, maybe more. And then it was kind of like I had a little bit of a withdrawal from you.
Yeah. And then there was COVID. So then we talked like every day about business owner stuff during COVID. So yeah,
that's right.
I'm missing my Kate time.
I know I'm missing my Blair time. We'll have to make something now that we're both vaccinated. We'll have to get together soon.
We will.
Yeah.
But we can talk. But today we will talk pelvic floor.
That's right. Lots of pelvic floor. And Casey's going to talk too. Hi, Casey.
Hi, yes, I'm here. I just wanted you gals to catch up a little bit first. Thanks, Blair, for coming on to our podcast. I think this is a topic that's very relevant to definitely our listeners and hopefully a lot of people who aren't listeners but become listeners because this catches their eye. But something I'm always wondering, and I know a lot of healthcare providers have the same question, is when is it appropriate to send a patient to you for a pelvic health appointment or for someone to choose to come see you on their own?
The best answer would be anytime you want. Because I, especially female athletes, and I know you guys talk about this a lot in terms of the demands of sport and running on the female athlete's body. And, the pelvic floor, when we think about the pelvic floor, it's a group of muscles, just like any other group of muscles in the body. It's something that we don't want to ignore. And just like if you were going to do, say, like a ready to run screen, or you just wanted to kind of go through, some of the different tests and things that are out there just to see where your body is as you're starting to build up, certainly you want to include your pelvic floor in that. So I would say really probably anyone at any time could come and just get a screening and kind of see where their baseline function is. And that's perfectly fine. We do that a lot. And it's actually, at least for me personally, as a physical therapist, I love working with all women at all stages in their lives, but I really love working with healthy athletic women too, who just want to know how they can kind of take their performance to the next level. So that is one thing. But I think, really anytime someone is experiencing any kind of urinary leakage, that's always a good indication to send them. And I think sometimes when we think about incontinence and the way we talk about it in society, the impression is that incontinence is only really like full-blown urinary leakage. Like you go out and you pee your pants and you're soaked. And so when we hear about women that are just having a couple drops of urine, whether it's right when they start their workout or at the end of their workout, or maybe on a day they had a hard workout and then they went home and they noticed it later, or with, coughing and sneezing and jumping, or whenever it's happening, any type of urinary leakage is not normal, even just a few drops. And that's not to say that like you might have a really full bladder and not be able to go to the bathroom and then you sneeze and it's like this random occasional thing. That's one thing. But if it's happening even on a semi-regular or irregular but recurrent basis, that's definitely something you want to check out. So that's one reason. Any pelvic pain, any pain, pressure, heaviness in the pelvic region that's onsetting with really any physical activity, and that's not just sport or athletic activity or exercise. It could be pain with sex. It could be a painful period. It could just be pain with everyday kind of household or work-related stuff too. We do a lot with women who have pelvic pain, even women who have back pain or hip pain that's not resolving. Sometimes the pelvic floor can be involved in that and is often missed because whomever you're working with might just be really laser focused on where the pain is, which could be the hip or the back, and they're not thinking about all those anatomical connections between the hip and the pelvic floor. And then my favorite group, besides my athletes that I love to work with, is pregnant women. I think in pregnancy, it's always good to get a screen, and absolutely 100% postpartum. Every woman who has a baby needs, I won't even say should, every woman who has a baby needs to see a pelvic PT. Just like you would go back to your OB after childbirth, you want to make sure that you're getting a pelvic floor screen with a PT.
Yes. And so you have started to answer many questions. So we're going to come back to at least 2 or 3 of those topics that you brought up. I think we could definitely dive deeper into each one of those. Since you brought up everybody needs to go to pelvic health PT, and I'm 100% on board. I send all of my athletes to you, or if they don't live close enough to some other people that do pelvic floor, because I think it's so important. But I actually saw you after I had my son, Andy. And even though I'm a PT, even though we work together, we're colleagues, I was still a little bit nervous to come see you. And I didn't really know what it entailed. It was before we wrote the book together, before, we had done some of the research. But because of that, I'd love for you to explain to our listeners what happens in a pelvic health appointment. Like, let's try to take some of that nervousness away if we can, and really just open it up and let people know what's going on.
There's really nothing to be nervous about. So I think a lot of people don't know what to expect. So I think just going over this is a really good thing. It's my job and it's the PT's job to make you as the patient feel comfortable. So I will tell you that everything that I do is always within the patient's comfort level and within the patient's level of consent. One part of the pelvic health exam, and this is kind of what I'll clear it up right off the bat just so we can address it, is the internal exam. And what I mean when I say internal exam, it is typically a vaginal exam. There are some reasons maybe why we would do a rectal exam instead of a vaginal exam, but I would say in most cases that's the exception and not the norm. We're typically doing a vaginal exam. And when I say a vaginal exam, it's not like when you go to the gynecologist. So my office, and I think a lot of my colleagues would probably say the same. We have a very comfortable office. It looks nice. It doesn't look clinical. You feel comfortable. You're not in stirrups on a table with a paper covering. Like, I use sheets, pillows, like warm lighting. Like, we try to make people feel good about it. So you're not going in, undressing down into a paper gown, putting your feet up in stirrups, kind of like it is at your annual exam. It's really a lot more, I don't want to say personalized, but a lot more sensitive and maybe intimate, if that's the right word, and just in terms of feeling comfortable. So the other piece of it is when we do an internal exam, it's not the same as what the gynecologist would do. So it's not let me just make sure I don't feel any lumps that aren't supposed to be there. Let me make sure things don't hurt. Let me check your uterus, etc. It's strictly a muscular and soft tissue, and then a little bit of like a neurological exam. How does the tissue feel? Does it feel normal? Does it feel dry? Does it feel tight? Does it seem like the muscles are in spasm, or can we feel trigger points? Very similar as if I were going to examine your shoulder or your quads or some other part of your body where there's muscles. The issue is we can only get to these muscles from the inside. So part of the exam involves looking at the tone of those muscles, seeing how things feel, and then assessing your strength and looking at the ability not only of those muscles to contract and squeeze, but also how do they relax and lengthen. And I know we're going to get into some of that, so I won't go into too much detail right now, but that is part of it. I also like to do sort of like an external visual exam of kind of the outside of the vulvar area just to make sure that there's not something abnormal there. There's some dermatological conditions that can cause some pelvic problems. So if I see something that doesn't look quite normal, I usually like to refer it out to someone. So I do look at that. And then besides that, and I will say that's usually the last thing I do, not the first thing I do. So I personally like to take an outside in approach because I do know that that's a sensitive thing for most women. And I want to respect your privacy and your comfort level as well. So I tend to start kind of like you would with a typical PT exam, spine range of motion, maybe some hip mobility and strength. I always assess the abdominal wall as well, especially with pregnancy, post-pregnancy, with really anyone who's had abdominal surgeries. A lot of times the abdomen is sort of a key to what's going on inside the pelvis as well. So it becomes a very hands-on specific exam targeted at these structures that affect our gynecological and urinary function from a musculoskeletal standpoint.
That was a very, very good explanation. Thank you.
Did I miss something? I'm like trying to think.
No. And actually, I think the truth is you do make it very comfortable. And it's just surprising when people go into that situation because we don't talk about it. Nobody knows what to expect. So if we can at least have an understanding of what's going to happen, it takes some of the fear away.
Yeah, I think the biggest issue, people come in and they're getting referred, which is great. But a lot of times they're not being told what's going to happen or why they're being referred. And so there's a lot of breaking down that barrier too. And I do a ton of talking. I like to make people feel comfortable. So it's not a very sterile, quiet environment by any means.
That's an important thing for us as if we're going to refer to you to try to start to explain and give at least a brief overview so they're not getting completely blindsided by where we're sending them, even though it could be super beneficial and it's totally worth any discomfort they might experience. One thing I'm wondering, so what things can come up during pregnancy itself where a woman should come and see you during some sort of issue they're having during their pregnancy?
If they're not in a situation where they're seeing great PTs like you guys. So I will pre-qualify this by saying that if you're already seeing a physical therapist, so a lot of times I get referrals from other PTs. And I probably should have said that before. So in that case, if I know they're seeing a good PT who have had all the hip back screening stuff happen, I'm probably not spending as much time there. But there are certain situations where that's not the case, that someone just finds me because they know I work with pregnant women. So some things that I see in pregnancy that are not necessarily pelvic floor specific, but could involve the pelvic floor are low back pain, which is the most common thing you see during and after pregnancy, and sacroiliac pain, or what we sometimes call pelvic girdle pain. And that can also include pubic symphysis pain. And for those of you who don't know what that is, the pubic symphysis is the joint right in the front of the pelvis. And so a lot of times in pregnancy, because of the widening of the pelvis, women can start to experience pain there. And it really affects their ability to kind of turn in bed and walk and climb stairs and things like that. So that's another reason why I do see women during pregnancy. See a lot of women with what will sometimes be referred to as a piriformis syndrome, kind of like hip muscle spasms. And I do see some women who have symptoms of incontinence during pregnancy. I would say probably the only time that maybe it's a little bit normal to have some incontinence would be in pregnancy, just because of the pressure of the uterus on the bladder and then all the ligamentous changes, plus the fact that women are just urinating more often during pregnancy because of fluid increase. So it does happen. And sometimes I do like to screen women then too, and just make sure that this is this is really just a during pregnancy thing, and give them some strategies, and then that brings up another thing, is just preventive. There's no reason that during pregnancy they couldn't come, just to learn how to use their pelvic floor the right way, to learn how to prepare for childbirth. I see a lot of women who want to help learn how to mobilize their pelvic region, learn how to breathe and push during delivery. I talk a lot with them about different childbirth positions. Another condition which we could talk about called diastasis recti is something that comes up a lot, which is where your abdominal muscles have a little bit of a split due to some fascial laxity during pregnancy as well. So there's a lot we can do for that, both during and after pregnancy. The list goes on and on.
It sure does. And let's talk a little bit about stress urinary incontinence, and particularly with running and endurance athletes. So there's a certain amount of intra-abdominal pressure that we have to maintain as athletes. every time we step on the ground, every time we move from one leg to the other. And when that intra-abdominal pressure is interrupted for one reason or another, we could have stress urinary incontinence or other issues. I would love it if you would take people through what that looks like and maybe talk about the pelvic floor piston a little bit. That's my favorite thing to talk about, by the way. And she's smiling over there, but talk about the pelvic floor piston with the intra-abdominal pressure and how that impacts the pelvic floor and maybe stress urinary incontinence.
Right. So just in general, not necessarily in relation to a pregnant woman.
No, I think in general, because what I want the other piece to be clear here is that you don't have to be pregnant or have had a baby or even be female to see pelvic health therapists. And so I think that we should talk about it generally across the board as an endurance athlete.
Sure. Yeah, that makes more sense. So just wanted to clarify that. So if the favorite thing to talk about is the pelvic floor piston, and I don't know if Kate's mentioned it on this podcast or not before. The way I like to think about this, and here's where the pelvic floor really fits in. We were just talking about intra-abdominal pressure, and the goal of our deep core, or what I sometimes call the anticipatory core, is to help maintain intra-abdominal pressure with activity. So a lot of things that we do cause alterations in intra-abdominal pressure, and that's normal. And our muscular system and our fascial system are designed to help support it and maintain it and transfer that load through activities. And one activity, for example, could be running like we're talking about, or really any kind of sport activity. So when we talk about what's called the anticipatory core, we have to include the pelvic floor. So we know when most people talk about the core, they talk about your abs. So the front part of the core is actually your deep abs, or what's known as your transverse abdominis. The back part are your deep low back muscles, known as the multifidus. The top is the diaphragm, right? So the diaphragm is what helps us breathe. And then, we go back to breathing. And then the bottom of the core, though, is your pelvic floor muscles. So that's the piece that gets left out. And I think it's just that whole stigma taboo thing about people wanting to talk about the pelvis and pelvic muscles when they're talking about other injuries. So it often gets left out. What has to happen in order for intra-abdominal pressure to stay the same or to be maintained or to be controlled is all those muscle groups have to work together. And our pelvic floor works with our diaphragm. So when we breathe in and the diaphragm contracts, your pelvic floor muscles actually lengthen in response to that. And that helps support the pelvic organs, and that helps to maintain the intra-abdominal pressure. When we exhale, the diaphragm passively relaxes, and at the same time, the pelvic floor muscles contract along with the abs and the low back. So they're always working together, but opposite. So as the diaphragm shortens, the pelvic floor lengthens. As the diaphragm lengthens, the pelvic floor shortens. And it's this nice coordinated motion, and that's what we call the pelvic floor piston, because if we look at it, like say on an ultrasound or an MRI, that's what it looks like. It looks like a pistoning movement. But that's what we're using to maintain that pressure. So if anything happens to disrupt that relationship, one of the results can be what's called stress urinary incontinence, or leaking urine at a time that you really don't want to urinate. And the reason for that is that the intra-abdominal pressure exceeds what's called the urethral pressure. So these muscles in and around the pelvic floor support the urethra, which is the structure where urine exits from the bladder. So if the pressure is too great in the abdomen, the structures around the urethra can't support that. And the result is there's leakage. That happens for one of two reasons. One is that those muscles are just weak. And certainly there are a lot of situations where the muscles are weak and need to be strengthened, but that can also happen because the muscles above, such as the diaphragm and the abdominals and the low back, might be overworked or overactive, or maybe the back is too stiff. For whatever reason, the intra-abdominal pressure is too high, and a normal strength pelvic floor and pelvic structures can't support it. So that's what results in urinary incontinence. And that's really important to understand, because as you said, Kate, not everybody who has this problem is someone who's had a baby or who has been pregnant. Sometimes women have never been pregnant. Sometimes this happens in teenagers. Sometimes this happens in men. That particular problem is not as common in men as some other pelvic floor problems, but male athletes do have problems dissipating the force of intra-abdominal pressure, and it does result in some other potential pelvic problems. And just because you have urinary incontinence doesn't mean that your pelvic floor muscles are weak. And that's probably the big take-home message. So I'm sure you guys have more questions that go with that.
I have to ask this question because I want you to talk about the difference between the weak pelvic floor and the overactive pelvic floor, because you can have an overactive pelvic floor or a weak pelvic floor and some of the same results. So everybody thinks they have to do Kegels, and that's not always the answer. So could you talk about that a little bit?
Sure. So and that's what I was getting to, but that's why I wanted to take that stop before I gave too much information without a pause. Conventional thought, what's out there in the world and in the public and what we see and read and maybe hear from our best friends or our parents or whatever is, oh, you're leaking, do Kegels or whatever, however you call them. It's kind of like tomato, Kegel, Kegel. But that always seems to be the generic answer. Oh, you're leaking, do Kegels. Oh, you're having trouble with, you feel like you have to pee all the time, do Kegels. Oh, you have pelvic pain, do Kegels. Well, it is very important, and it's necessary to have an awareness of how these muscles work. It's necessary to have a certain level of baseline strength and endurance in these muscles. But just because you are leaking urine does not mean those muscles are weak. And it's really important that we get that message across. And this really is why you need to see a pelvic floor therapist if you're having symptoms of incontinence, because sometimes it's not a weakness issue, it's an overactive issue. So again, going back to the intra-abdominal pressure, if the job of those muscles in the deep core is to maintain the pressure, if something's happening that's causing that pressure to rise, the pelvic muscles are going to contract to help support that and reduce that pressure. And if that happens too much or for too long a period of time or without a rest, or that's your habit, and the thing I'm going to talk about, and this could very well happen with running, but where I see it a lot is like with weightlifting, where people are just bracing and stiffening. And so I'm sure there's some people that are listening that either lift weights regularly or maybe have or still currently go to CrossFit or any type of that sort of strengthening exercise where they're used to kind of bracing and holding. And sometimes that bracing and holding can lead to what's called an overactive pelvic floor. And in that case, if we start to try to contract and strengthen the muscle, it can potentially make the problem worse, because in a very simplistic way, we are beginning to overwork a muscle that's already overworked. Just like if you had, and I always go back to other parts of the body. Let's say you had like a strain in your shoulder, like in your deltoid, like the last thing you're going to do is military press, because you know that this muscle is aggravated and overworked. And the more you push overhead, the worse you're going to feel. It's the same thing with the pelvic floor. But just like with your shoulder, you don't really know what's going on with it. So you go get it checked out. That's why you go get your pelvic floor checked out.
That's a really good definition. Thank you for that, Blair.
Yeah, and now that we understand a little bit more about stress urinary incontinence, and I know this answer is a little bit, it's very individual actually, but what can we expect from treatment for SUI? So what can people who are having this issue do about it?
Sure. So again, a lot of what we do is going to depend on the underlying reasons why there's a problem. We want to be able to restore, and there's a couple of different ways we go about this, but really the first job is to restore the full range of motion of the pelvic floor. That could be from resting to contracted to relaxed. Or we could say from like a resting length to a shorter length to a longer length. So in the case of someone who is weak, it really is about learning how to contract the pelvic floor. And we usually start that in isolation. So that is when we would prescribe a Kegel. Often we will do it in coordination with breathing, because we want to take advantage of the parts of the body that are working well or the parts of the body that work with the pelvic floor. So teaching someone how to breathe and do their Kegel at the same time on the exhale and taking advantage of that piston is a really good thing. If someone is not ready for that, because maybe they have an overactive pelvic floor, we typically spend some time teaching that patient how to calm things down. So we still do breathing, but it's a different purposed breathing. It's more of a relaxation breath, more about teaching you to use breath to let those muscles calm down. I do a lot of manual hands-on work, just like we would do with other muscles in the body, to get the muscles feeling a little more like that normal tone. Let's say they have some spasm or trigger points that need to be released. Let's say things feel tight and they need to stretch, learning specific exercises to allow that to happen. And then once that is better, the next step then becomes, now let's go back to retraining the muscle. So now that might be, okay, let's breathe and do the pelvic floor together. Let's learn how to coordinate. Fun fact about your pelvic floor. I don't know how many of you know about type 1 and type 2 muscle fibers. Type 1 muscle fibers are like our endurance muscle fibers, like our postural muscles, and type 2 are like the fast twitch strength muscles. The pelvic floor is 70% type 1 and 30% type 2. That means it's primarily an endurance muscle. So not only do we need to train the Kegel, but we need to train people to be able to repeat it over and over with activity. So our goal is to always work from that isolated contraction back to a sport or an activity specific task, whether that's jumping or hopping or bounding or squatting, whatever that might look like for that person. That's really the individualistic part, is how do we get from, okay, here's how you do a Kegel, to, okay, now you're going to go run and not leak. There's a lot of little steps of exercises in between that get you there. But at the same time, because of that fast twitch part, we also have to train the quick timing, which I really think with impact, like jumping and hopping and running and things like that, that quick contraction on impact is really, really important to retrain. So we'll do a lot of modified plyometric type stuff. I like to use the Pilates reformer and teach them how to jump on the reformer and contract their pelvic floor, or just teach them like little quick contractions that they can go home and practice too. So we can get very fun and very creative with these exercises.
We do. Since we work together a lot of our athletes, I'm constantly cueing the breath with their deadlifts, with their squats, with their plyometrics, lunges, everything that they're doing. I'm always cueing their breath. The other week, I think it was last week, someone said, okay, I know I'm holding my breath. I don't want to breathe. I'm sorry, but this is part of it. We really have to get this going. And you have to be able to do it without thinking about it in order for this piston to work correctly. So it's kind of a fun thing to work with, but cueing that breath every time you're exercising, I think, is so helpful.
And I think that's the point, is it's different for everyone. And so in some people, I spend a lot of time making them focus on maybe the pelvic floor piece, where in other people, if I can just get them to focus on their breath, everything else falls into place. It really is a person by person situation, what that's going to look like.
Let's move a little bit down the spectrum a little bit and talk about pelvic floor prolapse. I taught a course recently where it was a running athlete course, and we were talking about prolapse and how one of the major questions of healthcare providers, so I know this is a huge question with the running population, is can you run with prolapse, and what do we do about it? So there's been a lot more research out recently involving pelvic floor prolapse, or POP, if you will call it that, because that's what the abbreviation is, and how we can actually do heavier things. We can do more strength training when we have it. And most women that can do that strength training or be more active do better. So can you kind of speak to that a little bit?
Yeah, and there's a lot of differing schools of thought on that, but I am definitely in the camp of, if you can do it, that's better for you. So for those of you who maybe don't know that term, pelvic organ prolapse, what that means is, and I apologize if this is like a little graphic, but what that means is it's almost like a herniation of your pelvic organs. It's typically like the bladder or the uterus into the vaginal wall. So it doesn't mean that like your bladder is literally falling out. It means that the vaginal wall, which is smooth muscle, is weak. And so there's like a little bulging that occurs because it can't support the organ. And so typically what that feels like in women is it feels like a heaviness or a pressure, or in more severe cases, it may feel like you may notice that something's coming out. Usually where I hear people notice it is like, oh, I was taking a shower and I bent down to wash and I noticed there was something there. That's usually how a lot of women discover it. one of the biggest risk factors for it, but certainly not the only risk factor, is a vaginal delivery. It is something that you need to be aware of during pregnancy and postpartum. But old thought was, okay, you have pelvic organ prolapse. The only thing you can possibly do to help yourself is A, stop exercising, B, don't do any sit-ups or crunches ever, and C, go get surgery. As we learn more and we have more PTs that are really invested in helping women with some of these problems that can occur postpartum, we're starting to realize that that's not the case. What we know is, especially like in moderate to more severe prolapses, we probably cannot change if there is so let me backtrack. We talked about all the intra-abdominal pressure stuff. So there's basically two reasons women develop prolapse, kind of like incontinence. One is their ligamentous support is very weak, and that could happen from pregnancy, childbirth, connective tissue dysfunction. A lot of women who are hypermobile may be more susceptible to it just because their connective tissue tends to not have the same tensile strength. Hormonally, that might be, and I know we're going to get into that later too, that might be another reason why. But the other reason, just like with incontinence, is really about that intra-abdominal pressure. And if the intra-abdominal pressure is greater than what the tissues can support, just like incontinence, it could result in prolapse. And so what we found is, in some cases, while we may not be able to change the tissue defect, like if there's laxity in the tissue, there might always be laxity in the tissue. But if we can control intra-abdominal pressure and we can teach women how to use their bodies, in cases of less, I would say mild to maybe moderate prolapse, we might actually be able to improve it. But certainly in most cases of mild and moderate prolapse, we can help women reduce their symptoms and function. And I think that's really important, is that we're able to delineate between severity of problem and symptoms and function. And one of the reasons for that is that the surgery to correct it is not a super successful surgery. Like, it fails 1/3 of the time, I believe, especially in younger women who are active. If you have this surgery at a young age when you're active, you may end up needing a second surgery. And so we can teach women how to do more. And I think what we're finding is, the more we learn how to use our muscles and keep them strong, the better off we're going to be, because the stronger our bodies are in general, the more support we're going to have for our pelvic organs. And the more that we work on supporting that deep core, the more we're going to be able to support our entire body through things. So to go back to like running with prolapse, it's a tough call. But for me, if a woman has good neuromuscular control, so she can contract and relax her pelvic floor through the full range of motion, if she's not holding her breath while she's running, if she can jump on 2 feet and hop on one leg and not increase her symptoms, I have no problem letting a woman go and run. So I think the name of the game is symptoms, and for every person that's going to be different. Some women don't want to feel anything. They're like, if I'm not 100%, I don't want to do it. And that's her choice. Other women feel like, if I can get through it and it's not worse, I'm fine. So there's a range there, but I think if we can teach a woman how to control her symptoms and how to control that heaviness, pressure feeling while she's doing high impact activities, which we really can through some strengthening, then she might be okay to go running. So that's one thing we can do. The other thing we can do is there are a number of supports we can use, whether it's an external support, like a supportive like undergarment, maybe like some sorts of like compression, and there's things that we can use externally. There's also something we can use internally called a pessary. I think that's something that's in this country very highly underutilized. It's something they're using a lot in Europe and the UK to help women with prolapse, and Australia, because I feel like Australia does everything first and better for some reason, but I know they use it there, and here for whatever reason it doesn't get utilized as much. And I think it's a tool that I think we have to look at it as a tool, just like you would wear an ankle brace or maybe a knee sleeve, if that gave you like that little bit of confidence to go complete something that you wouldn't be able to do otherwise. A pessary is a great way that we can exercise and strengthen and do more high impact activities and prevent our prolapse symptoms from worsening.
Thank you for going through that, because I think it's a topic that's a hot topic and not a lot of people really understand it.
Yeah, so this is a little bit of a pivot, but I think this is the last topic we wanted to cover today, and that's menopause and perimenopause. So we have this decrease in estrogen and progesterone during this time. So what does this mean for the pelvic floor and pelvic health of our runners? And what are the consequences of menopause or perimenopause?
Sure. So where to start without going into it for a very long time. So the first thing I want to say, and I think this is really important too, is that menopause is usually defined by going 1 year without a menstrual period. A woman who has had, even if you're having irregular cycles, if you have a period and you go 10 months and then you have a period, you are not in menopause. The actual true definition is 1 year. And we can't diagnose menopause until after it happens. But the changes associated with menopause onset 5 to 10 years before you stop ovulating. Some of these hormonal changes, like the reducing estrogen and progesterone, are occurring before we even know they're occurring, because while all that's happening, we may be still having regular periods. And it's not until our periods stop that we truly know that we're in menopause. Maintaining your pelvic health is really, really important. And estrogen is that's another hot topic, and it's another sort of buzzword, and it gets a lot of good and bad, but estrogen is something that we need for a lot of reasons. In terms of the pelvic floor, when we lose estrogen and or we have an imbalance of estrogen and progesterone, because what happens is one drops before the other and then you've got like this imbalance. So with the imbalance of estrogen and progesterone and with the loss of estrogen, the pelvic floor muscle loses strength. Just like other muscles in our body lose strength with loss in estrogen, so do our pelvic floor muscles. So that's one thing we have to be aware of, is that our pelvic floor muscles are not going to be as strong. That's why we hear about women who maybe never had a problem in their life until they turn 55 or 60, and now all of a sudden they're leaking. It's usually because of hormonal changes. And it may be coupled with maybe they had a vaginal delivery, maybe they've had some pelvic floor dysfunction, but they've been able to compensate up until this point. So that's one thing to keep in mind, is that muscle strength is going to reduce. Ligamentous strength is also going to reduce. So women become more susceptible to pelvic organ prolapse. So all those things I just talked about, I see a lot of women who have no problems with prolapse until they're the same age. And so unfortunately, what I'm seeing in that age group is the prognosis is not as good as it is in the younger women who are having babies and maybe experiencing some prolapse symptoms. The older women, I think, just because they can't build the strength as much post-menopause, don't do as well. But that's certainly something that could happen as well. So we've got reduced strength, which could lead to leaking. We have reduced kind of integrity of the tissue, which can lead to prolapse. And then the other thing that happens is the tissue becomes like a little bit more fragile and less lubricated. So we run into problems with pain with intercourse because the tissue is just really not the same as it was. So those are sort of the big things that you have to be aware of. There's actually a term for it called genitourinary syndrome of menopause. So that is a real thing, and that refers to the changes in tissue quality and the changes in strength and some of the things that can happen because of it. But I think what we can do is really, maximize what we're doing going into menopause. So the stronger we are going in, the more it's going to help us during. So that's the first thing I like to say. Without getting too much into it, there are certain foods we can eat that are what are called phytoestrogens. So they mimic estrogen. So that's something else we can do through diet. That is not my area of expertise, but if that's something that interests you, I would definitely look into what foods mimic estrogen. The third thing we can talk about is like when that perimenopause time is really coming on, is maybe talking to your doctor about the possibility of like a hormone replacement, even if it's just a vaginal estrogen, that can really help your tissue quality locally at the pelvic floor. And we're learning that some of the cancer risks that we had once believed were associated with the use of estrogen, A, are not as great as we once believed, but B, they're really low with this vaginal estrogen. So that's something else to consider. And that's something that if you think that you would benefit from that, I would definitely discuss that with your doctor. As PTs, we can't prescribe it, but it's something I always bring up to women, especially active women who want to stay active. It can really be a little bit preventative as well. So the most important thing is that the stuff we do now in our 30s and 40s, and even our 20s, if you've got some younger listeners here, but those are really going to help us once we get into our 50s and 60s. The more you can do now, the better you're going to be later.
I think that's for everything that we do when we look at our health from like a holistic perspective. Everything we're doing now, it comes up later.
Absolutely. Good thing to end on.
And the bad things too, which we don't do, of course. If you could give our athletes, like our runners and our endurance athletes, any tips, top 3 tips for endurance athletes when it comes to pelvic floor and pelvic health, what would they be?
Don't forget to take time to I'm going to call it stretch and relax. I think it's very important that you don't just train. Like I always tell my people, don't train like you're always running a race. You need to have that cycle on, cycle off, and that pelvic floor relaxation and rest is equally important. And that balance, finding time to get the relaxation in, whether it's through just some guided breathing, yoga, maybe just, whatever kind of gentle stretching or mobility work you like to do. I think everybody's got something different that works for them. There's no one right answer. I absolutely recommend that. My big tip is just, if you have any concerns, or especially if you have any symptoms, see a pelvic floor PT. That probably should have been first, but I'll say it second, just because I'm trying to spit them out. But that's always the first and foremost. I think the third one I would say is, don't be afraid to talk about it. What I see with athletes, there's a large percentage of endurance athletes. There was a study and it looked at I think 30% and these were novice endurance athletes, experienced some pelvic floor symptom, whether it was urinary incontinence, fecal incontinence, or pelvic organ prolapse. It is very, very common in this population, and it is something that's not talked about. Don't be afraid to talk about it, because I think you will be surprised how many people may be going through the same things you're going through. There's strength in numbers. And I think the more we can talk about it, the more it's going to be addressed specifically in the athletic population, and not be looked at as, well, that's just something that happens to weak women who have babies, because that's absolutely not true.
And I love how you said it doesn't have to, you don't have to have a baby to go through this. And I think I just want to continually stress that plenty of women who've had issues that have never had a baby. Thanks, Blair. I'm so happy you're here. I hope all of our listeners learned as much as I did.
Awesome. Well, thank you guys for having me. I will always come back if there's anything else you want to talk about. Put that out there now.
We'll find something else.
We'll find something back. We always do. But thanks everyone for listening.
Yeah, thank you so much, Blair. I learned a lot. I know I'm going to have to go back and listen to this one to really glean everything from it. But can you tell our listeners where to find you and a little bit about your practice?
Sure. So as Kate mentioned at the beginning, my practice is called Catalyst Physical Therapy, and I am on the north side of Metro Atlanta. Our website is catalystga.com, and our Instagram is at catalyst_ga.com. So we're also on Facebook. It's Catalyst GA without the underscore on Facebook, but it's with the underscore on Instagram. Feel free to leave us a message, give us a follow. All our contact information is on our website if you feel like you'd like to come in and make an appointment too.
Well, thank you very much, Blair.
Yeah, thanks, Blair.
Sure. Thanks, you guys. Have a great night.
Thank you for joining us today. We're so glad you're here.
If you love this podcast, please show us some love and write us a review. We're totally serious. Write us a review and subscribe wherever you listen to your podcast. It really helps us to increase the visibility of our show and reach more endurance athletes everywhere.
And remember that training is so much more than miles.
See you later.
See you later.